The child had bilateral nasal obstruction which was progressive. It started from the right nasal cavity and progressed to the left. There was mouth breathing since 3 months with snoring. There were no spells of sleep apnea. There was nasal discharge which was mucoid in consistency, non-foul smelling, non-blood tinged, with decreased smell perception since 2 months. Bilateral watching of eyes, non-prurient, initially occasional and then persistent since 1.5 months. Bilateral protrusion of the eyeball since 5 days, which was non-painful, with decreased vision since 3 days. The negative history given by the parents was there was no history of headache, facial pain and numbness, facial heaviness, fever, cough, nasal bleeding, earache, decreased hearing, ringing sensation in ear, double vision, dizziness, photophobia, itching of eyes, weight loss, loss of appetite, and trauma. The child had history of pruritic rash at around which developed around 3 to 6 months of age. It subsided by 2 years of age, and the episode of the rash was aggravated during the winter season, which was relieved on topical emollients and topical steroid creams which were prescribed by the doctor. The child also had history of rhinitis in the childhood, which was relieved on medication. So, anti-allergic syrups were given to the patient. Steroids were not given, sir. Only topical steroid for the itching were given, sir. Past history, there was no history of diabetes, hypertension, tuberculosis, malignancy, thyroid dysfunction or asthma. There was no surgical history, no drug allergy, no food allergy, and no trauma history. The child was vegetarian, appetite was normal, bowel and bladder habits were normal, sleep was adequate, skin and hair were normal. The child was a full-term normal hospital delivery with a birth weight of 2.75 kgs. The child cried immediately after birth, and there was no history of hospital admission. The developmental history was within normal limits, and the immunization history was up to mark, and the BCG mark was seen. The mother also had similar complaints of rhinitis, which aggravated during the winter season, and they were also relieved on medication, but there was no formal diagnosis made in the mother, and the antenatal history was uneventful, and the paternal history was not significant. To summarize, we have a 9-year-old boy, fully immunized, with bilateral nasal obstruction and nasal discharge since 3 months, which was mucoid, non-foul smelling, non-blood tinged, with watering of eyes since 1.5 months, bilateral porptosis since 5 days, which was painless, and progressive decrease in vision since 3 days, with a history of recurrent episodes of allergic rhinitis and eczematous rash in the childhood, with a maternal history of episodes of watching of nose and sneezing, which relieved on medication. There was no history of trauma. So can anyone think of any differentials based on the history of the child? To classify the differential diagnosis, we broadly classify into 5 groups: be it the infective or the inflammatory, thyroid dysfunction, neoplasm, vascular or vital disorders, and trauma. Under the infective and the inflammatory criteria, we've divided it into the eye differentials and the ENT differentials. We have orbital cellulitis, orbital pseudotumor, myositis of ocular muscle, orbital abscess, cavernous sinus thrombosis, allergic fungal rhinosinusitis, ethmoid mucocele, infected angiocrinal polyp, juvenile nasal angiofibroma, rhinolith, acute rhinosinusitis, chronic rhinosinusitis without polyposis, chronic rhinosinusitis with polyposis. Under thyroid, we have the Graves' disease. Neoplastic includes sinoorbital tumor, capillary hemangioma, rhabdomyosarcoma, neuroblastoma, cavernous hemangioma. The vascular or the orbital disorders include arteriovenous fistula, orbital hematoma, orbital varices, cavernous sinus thrombosis, and the trauma. Since there is no history of trauma to the patient,
what do you mean by porptosis?
So porptosis is the outward bulging of the eyeball. We confirm the porptosis by the measurement if moving on to the examination, the general examination of the patient was normal. The ENT examination, the nose, there was widened nasal bridge with increase in intercanthal distance. The skin over the nose was normal. Now, question to the audience. Sorry, sir. So the normal range is 30 to 31 mm, but if we say in a layman language, the distance between the two eyes is the measurement of one eye.
Which mode is increasing? Which side? If we widen mode, is increasing?
So it is because of the ethmoid. Can anyone name this instrument which we use in OPDs for the ENT examination? This is the Thundercombs nasal speculum. It is mainly used to do the anterior rhinoscopic examination of the patient. Coming to the anterior rhinoscopic examination of our patient, the nasal vestibule showed skin excoriation. Nasal septum was mildly deviated towards the right. The nasal mucosa was pale and edematous. The nasal floor covered with mucoid discharge. Nasal cavity showed bilateral polypoid mass filling the nostril. The inferior turbinate were hypertrophied. Middle turbinate was edematous and polypoidal. Middle meatus showed polypoidal mass. Coming to the posterior rhinoscopic examination, the posterior part of the nasal septum was edematous. Both choana were filled with polypoidal mass. Roof and the posterior wall of the nasopharynx showed grade 2 adenoid enlargement with mucoid secretion, and the opening of the eustachian tube and fossa of Rosenmuller on both sides was normal. Then we performed few functional tests. So the first two tests are mainly performed to check if there's nasal obstruction bilaterally or unilateral. First we did the cold spatula test. In this we take a spatula and we place it under the nostril of the patient and we ask the patient to exhale. In normal cases, the warm air from the nasal cavity, when it touches the cold spatula, we see fogging. But since there was case of bilateral nasal obstruction, therefore we could see decreased fogging on the spatula. Then we performed a cotton wool test. In this, we take a cotton wick and we place it in front of the nostril of the patient and we ask the patient to exhale. Normally, we see the fibers evidently moving, but since there was bilateral nasal obstruction, so on both the nostrils, there was decrease in mobility, movement of the fibers. Then we did a probe test. Probe test is basically done to see the polyps which were there in the nose. The origin of the polyp is seen with the probe test, that whether it arises from the nasal septum, the nasal floor, or the lateral nasal cavity, lateral nasal wall. In this case, we could see that the nasal floor was free of the polyp, the nasal septum was free of the polyp. Then we did a Cottel's test. In this, we take the skin on the lateral part of the nose and we pull it laterally. If there is improvement in the nasal obstruction, it means that the obstruction was mainly because of the nasal valve. But since here we had polyps, therefore it was negative. Then we did the sinus tenderness test. In this, we press along all the sinuses of the nose to see if there is any sinus tenderness present in the sinuses. Sir, it was absent in this case. Coming to nasal endoscopy, this is the endoscopic unit which is used to do the nasal endoscopy of the patient. Here in this picture we see that this is a nasal polyp which was present in the nostril of the patient, and these are the mucoid secretions which were present in the nasal cavity. The local examination of the oral cavity was normal. The local examination of the oropharynx was normal. There was no cervical lymphadenopathy. Bilateral tympanic membrane was intact and hearing was within normal limits. Now, after doing the general examination and the functional test of the patient, we can rule out few of these differential diagnoses from our patient. To begin with the ethmoid mucoside, since ethmoid mucoside is mostly unilateral plus it is invasive, therefore we can rule it out from this case. Then we have infected antrochoanal polyp. In case of antrochoanal polyp, it mainly arises from the maxillary sinus and can extend to the choana. This differential has to be ruled out through radiodiagnosis. We cannot rule out it here in this point. Then coming to juvenile radial angiofibroma, in this we have a vascular aggressive mass which bleeds, and the patient also presents with a history of bleeding. Since there was no history of bleeding in this case, therefore we can rule it out. Coming to rhinolith, there's no history of foreign body in the nose. Plus, in cases of rhinolith, we have foul-smelling discharge coming from the nasal cavity, and it is also mostly unilateral. The discharge here was non-foul smelling, and since it was bilaterally involved, therefore we can rule out rhinolith. Coming to acute rhinosinusitis, we can think of this, but since the history is given that the episode was since 3 months, so when it crosses 3 months, it becomes a chronic case, therefore it becomes chronic rhinosinusitis, so we rule out acute. Then coming to chronic rhinosinusitis without polyposis, this can also be ruled out since we can easily see the nasal polyp in the anterior rhinoscopy as well as in the nasal endoscopy. Then coming to chronic rhinosinusitis with polyposis, this has to be ruled out after the radiological examination of the patient. Now I'd like to invite Dr. Amneet from Department of Ophthalmology for the ophthalmic examination of the patient.
Good morning, respected faculty, seniors, and all my dear colleagues. This patient was referred to the IOPD in view of complaints of diminished vision and bilateral proptosis. An ophthalmic examination was conducted. Vision in the right eye was found to be 6/9, not improving of in full. Left eye 6/12 part, no improvement. Orbit examination was done. Exophthalmometry, which is the distance between the lateral orbital margins to the apex of the cornea, was done. It was found to be 20 millimeters in the right eye and 22 millimeters in the left eye, which is more than the normal range of this age. This shows proptosis in both the eyes, left more than right, which was bilateral, sudden, progressive, painless, and non-pulsatile. Intercanthal distance, that is the distance between the medial canthi of both the eyes represented by the red arrow, was measured as 40 millimeters. Ideally, the intercanthal distance should be equal to the palpebral aperture. In this patient, the palpebral aperture measured 30 millimeters. Clearly, the intercanthal distance is more than the palpebral aperture, therefore we term it as telecanthus. Interpupillary distance was normal. Eyelids. Normally, the upper eyelid covers 2 millimeters of the cornea superiorly, but in this patient, it just covers 1 millimeters of cornea. The lower eyelid usually touches the limbus, but in this patient, it is 2 millimeters below the limbus. This again points out towards proptosis. No, sir, no ptosis. Extraocular movements in both the eyes were free and full in all directions of gaze. This rules out any direct muscle involvement or cranial nerve involvement. Slit lamp examination was done. The
cranial nerve you think should be involved?
Sir, third or...
What is the name of third?
Oculomotor nerve, sir.
What is the name of fourth?
Trochlear nerve, sir.
And sixth?
Abducer. Abducer.
Trigeminally or this one?
Sir, not in the ocular movement, sir.
Sinuses? What's the eye से relation इसलिए बता दो मतलब ये maxillary side
slit lamp exam
department इसमें gynecology से भी तो सब पढ़ाया करो 10
Slit lamp examination was done. Conjunctiva and cornea was within normal limits. Pupil was round, regular, and reactive. Intraocular pressures in the right eye and the left eye were 13 and 12 millimeters of mercury. Fundus examination was normal. This showed no signs of papillary. Now we come to differential diagnosis, which we divide into 4 categories: infective, inflammatory, neoplastic, thyroid, and vascular disorders. Firstly, orbital cellulitis or abscess. The patient presents with a lot of pain, eyelid edema, conjunctival chemosis, which is not there in this patient, therefore we rule out orbital cellulitis. Orbital pseudotumor refers to the idiopathic inflammatory disease of the orbit. This characterized by there is pain on the movement of thalmoplasia and conjunctival chemosis, which is absent in this patient. Orbital myositis involves the extraocular muscles. Therefore, it would lead to pain on eye movements and also ophthalmoplegia, which is absent in this patient. So, therefore, we rule out orbital myositis. Rhabdomyosarcoma and hemangioma usually presents with unilateral proptosis. Therefore, these are ruled out. Optic nerve glioma shows disc edema, as well as later on stages it shows disc atrophy, which is not there as the fundus is absolutely normal. Therefore, optic nerve glioma is ruled out. Carotid cavernous fistula typically presents with pulsatile proptosis along with conjunctival chemosis, which is not there in this patient. Cavernous sinus thrombosis affects the 3rd and 6th nerve, leading to ophthalmoplegia, as well as leads to congestion of the veins, retinal veins and conjunctival veins, which is not there in this patient. Orbital varices typically present as unilateral proptosis along with a lot of conjunctival chemosis, which is absent in this patient, therefore this is ruled out. To further rule out the differentials on the basis of radiological findings, I would like to invite Dr. Pragya from the Department of Radiology.
Produce proptosis.
Sir, it could increase, it could put pressure on the intracorneal department and on the intracorneal compartment, and due to that pressure, there is proptosis, outward bulging of the eyeballs.
Good morning, respected teachers, seniors and my dear colleagues. First, we'll discuss the normal X-ray PLS Waters view. As we can see that in the normal X-ray, all the sinuses appear radiolucent since the air is present within them. But in our patient, we can see that the maxillary, the ethmoid, the frontal and the sphenoid sinuses are obscured. They have radio density present in them. So, and there is mucosal thickening in the maxillary sinuses. Bilateral nasal cavities are hazy. The findings are suggestive of pansinusitis. These are the commonly used views for X-ray PNS. Occipitomental view, also known as the Waters view, it is used for visualization of most of the sinuses simultaneously, including the sphenoid sinuses. The next is the Cardwell's view. This view is another PA view of skull, which is caudally angled approximately 15 degrees. This allows minimum radiation to the orbits. It is especially good for visualization of the frontal sinuses. The normal CT anatomy. Here we can see that the nasal septum is present in the midline, dividing the nasal cavity into two halves. We can see the middle and inferior turbinates with their myitis. Bilateral maxillary sinuses are well visualized with the osteomeatal complex, which consists of the primary ostium, the infundibulum, the uncinate process, and the hiatus semilunaris. In the axial section, we can also see the ethmoid and sphenoid sinuses. The frontal sinuses can be visualized in axial or the sagittal views. In the soft tissue window of plain CT PNS, we see pansinusitis with significant expansion of the sinuses and characteristic hyperattenuating material within them. There is widening of bilateral maxillary ostium, mucosal thickening, which is extending into the left nasal cavity up to the left posterior choana. In the bone window CT images, there is thinning of the medial wall of the orbits with lateral bowing closely abutting the medial rectus muscle. No obvious intraorbital extension is seen, which is possibly limited by the periosteum. No obvious superior bony erosions are seen of the cribriform plate or the ethmoid roof. No obvious intracranial extension is seen. On the basis of CT, following differentials can be made. The sinonasal mucocele polyps and neoplastic etiology can be ruled out on the basis of the points which are against the diagnosis, which includes unilaterality on all three of them. The sinonasal polyps are usually hypodense on CT and causes focal thinning due to pressure effects, which is contrary to the increased thinning of all the sinuses in arteries. The age and the invasiveness of neoplastic etiology rules this out too. On MRI, we can see unenhanced Steven images shows expansile hypointense material within the center of the sinuses. On STIR, it shows marked low signal intensity mimicking normal aerated sinuses. This characteristic low signal intensity on T2 weighted images is attributed to high concentration of various metals such as iron, magnesium, manganese, which is concentrated by fungal organisms. Or this low signal T2 can be attributed to high protein and low water content of mucin. In post-contrast images, the T1 images, we can see that the peripheral enhancement of the mucosa is present. In coronal sections, we can see lateral bowing of medial rectus closely abutting the muscle. However, no intraorbital extension or intracranial extension is noted. So on the basis of MRI, we can rule out the inspissated secretions which are present in chronic sinusitis, as they do not cause expansion of the sinuses or bony thinning. Secretions appear hyper or hypointense on T2 weighted images based on the protein content, which is contrary to the signal void which is present in this case. So we come to the provisional diagnosis of non-invasive fungal rhinosinusitis, which is further classified into two, which is allergic fungal rhinosinusitis or the fungal ball. We can rule out fungal ball as there is no intralesional calcifications present, which is characteristic of a fungal ball, and the fungal balls are usually unilateral or limited to a single sinus. Here in this case, we saw pansinusitis was present. So the points which are in favor of allergic fungal sinusitis includes double density sign on CT, hypointensity on T1 weighted images, and signal void in T2 weighted images, expansion of sinuses with thinning of bones, peripheral enhancement on post-contrast images, pansinusitis, young age and immunocompetent patient. So the radiological diagnosis points towards allergic fungal rhinosinusitis. Thank you.
Along with the radiological investigations, we also performed few blood investigations in which we included CBC, kidney function test, liver function test, viral markers, thyroid profile, bleeding profile. On CBC, we could evidently see that the eosinophil count was increased. We also performed total serum IgE levels, which was significantly raised. Also, serum specific IgE for aspergillosis was raised. We performed mucin cytology and nasal smear for KOH. In mucin cytology, we could see neutrophil, scattered eosinophils, fungal hyphae, and charcoal-laden crystals were seen. Then we also saw on KOH mount septate fungal hyphae, which showed acute branching. This acute branching of the septate hyphae is a characteristic of aspergillosis. So final diagnosis on the basis of history, examination and the investigations is allergic fungal rhinosinusitis. Now I would like to call Dr. Priyanshi from Department of ENT to further discuss the management of the patient.
Priyanshi, before you start, I'll ask the same question again. Was your clinical diagnosis allergic fungal rhinosinusitis, or is it a retrospective diagnosis after all this? What was the clinical diagnosis when the patient came?
Clinically suspected allergic fungal rhinosinusitis. Good morning, my respected seniors, teachers, and my colleagues. Sir, on the basis of clinical examination, we did have allergic fungal rhinosinusitis as our differential, along with chronic rhinosinusitis with polyposis. So,
non-immunocompromised.
okay, so allergic fungal and CRS with polyposis is more common, but given the age, in the age we would first think of allergic fungal. So CRS with polyposis comes after 2022. So since we have established our diagnosis as allergic fungal rhinosinusitis, we have a brief overview of what it is. It is a type 1 mediated allergic response to a fungal antigen in an atopic individual. Now what is an atopic individual? Atopy means a genetic predisposition in an individual to give an allergic response. So how did we justify? We justified it on the basis of Benton-Crone criteria. For it to be AFRS, allow me to use the mnemonic. For it to be AFRS, we need all the major criteria to be fulfilled, which is nasal polyposis on clinical examination, eosinophilic mucin that we saw in nasal endoscopy, type 1 hypersensitivity reaction evident with raised serum Ig levels, and radiographic findings which have been discussed with my colleague, and fungi on staining which we saw in microbiology. The minor criteria are not an essential requisite for it to be proved, but minor criteria is an additive. In our case, we found fungal culture, Charcot-laden crystals, and serum eosinophilia. A marked distinction over these major and minor criteria is unlike our Jones criteria, which find it rheumatic fever, where we need one major, two minor. Here we have to substantiate all major criteria to prove AFRS. So moving on to management.
How important is the history of atopy and eczema for childhood origin?
So more than 70% of these children give us a history of atopy.
It's not included in the criteria.
So atopy is, we are justifying it with the basis of type 1 hypersensitivity reaction, and also that our child had eczema. However, there was no food allergy. So when we talk about it, it is so. So in the management, is AFRS an emergency? Usually it is not. But in this patient, since the intracorneal pressure had been increased and the optic nerve had been involved, this is an emergency. So the three paradigms of managing this patient were a surgical debridement to reduce the allergen load, a medical management because it is an allergic response, and a recurrence prevention. So surgical management classifies into an open approach and an endoscopic approach. And the open approach will have a Weber-Ferguson opening the maxillary sinuses externally, Carvel luck where we make an incision in the sublabial region, and an endoscope. Now we all have been very familiar with the word endoscopic sinus surgery given the mucor epidemic which we had in 2021. So this term is basically a sinus surgery done through an endoscope. But the rationale behind doing this surgery in mucormycosis was different. Since it is an invasive fungus, very lethal, we had to do a surgical debridement where each and every mucosa of the sinus along with the necrotic bone was removed. But the rationale of doing this surgery in AFRS is different. Here we don't...
So what is the difference, major difference, or basic difference of mucormycosis and aspergillosis from the surgical problem?
So it is not the fungus that is important, sir. It is our immune response to that fungus. So aspergillus in neutropenic patients can also give an invasive response.
In COVID pandemic, why they were like...
So mucormycosis is more common as an invasive fungus, but aspergillus can also be an invasive fungus. So in our Indian data, we found that 96% of the cases were mucor. So because in critically ill patients, mucormycosis...
I read that the difference mucormycosis, it is usually invasive.
Yes, sir.
This one is.
Yes.
while the aspergillal process is not the invasive, it is the burden of the fungal growth.
Sir, aspergillus भी invasive हो सकता है if the patient is neutropenic. But in invasive fungus category, the more common is mucor. Yes, sir. So aspergillus can behave as an indolent fungus also and an allergen fungus also. So here the target of doing a sinus surgery is to reduce the allergen load. Now a brief recap of CAM, which is COVID-associated mucormycosis. It is interesting to note that not all the countries of the world reported mucormycosis during the pandemic. India itself reported 96% of the total documented cases, and the entire US, including North and South, reported only 86 cases. So the world data is very skewed since there was no reporting from a major countries. In India, as per 1st of June 2021, we have a total of 41,000 cases reported, 34,600 operated with a mortality of 3,200. In our institute, we had 87 diagnoses of mucormycosis, 85 operated and 8 mortality. The mortality of 10% that we see here is because of the extensive grade of invasion intracoronally and also intracranially. Now, while the child was undergoing pre-anesthetic workup, we started that patient on methylprednisolone on a bolus dose and a maintenance dose under the cover of an antibiotic, an antifungal, decongestant and other supportive treatment. Now, I would like to invite Dr. Disha from the Department of Anaesthesiology to tell us the concerns regarding such a major surgery. Thank you.
Good morning, respected faculties, seniors and all my dear colleagues. I will be discussing the anesthetic management of the case. Before shifting the patient to the operation theatre, pre-anesthetic evaluation was done. On examination, vitals were stable and Malam Patti was grade 1. What were the anesthetic challenges? These included pediatric patient, allergic hyperreactive inflammatory airway, disease involving the multiple paranasal sinus with bleeding tendency, sharing airway with the surgeon, continuous irrigation of the nasal passage and sinuses, increasing the risk of aspiration, depth of anesthesia was to be maintained, risk of blood loss and hypothermia. Anesthetic management plan included pre-medicating the child for the proper angiolysis, smooth induction and intubation, fluid, electrolyte and temperature management. Our focus was on maintaining and promoting induced hypertension and circulatory manipulation intraoperatively, await extubation without post-operative pain and post-operative nausea and vomiting. The goal for this surgery is to reduce the bleeding from the capillary circulation by decreasing the patient's mean arterial pressure and by local vasoconstriction. As we know, this surgery and the hemorrhage obscures the endoscopic view for the surgeon. So let's discuss about the controlled hypertension. It is basically lowering of the arterial blood pressure in a predictable and safe manner, ensuring perfusion to all the vital organs. A mean arterial pressure of 30% below a patient's baseline mean arterial pressure. In ASA class 1, mean arterial pressure of 50 mmHg, and for the elderly, minimum 80 mmHg is considered to be acceptable. So what were the methods of induced hypertension that we did for the surgery? Non-pharmacological included the positioning. Reverse Treadlenberg position was to be maintained. And for the pharmacological, we can use one drug or a combination of drug. In this case, we used induction agent propofol, and for the maintenance, drug dexmedetomidine infusion was started. Intraoperative monitoring included routine monitoring as per ASA recommendation. Also, for this case, special monitors were attached, which included invasive BP after the induction for beat-to-beat blood pressure measurement. Also, ECG, SpO2, blood pressure, temperature and urine output was to be monitored. Anesthetic management included giving the pre-medication, induction and maintenance of the case with the infusion of dexmedetomidine in the dose of 0.3 to 0.7 microgram per kg per hour to provide the hypotensive anesthesia. Intraoperative management focuses on preventing the hypothermia. For these, warming blankets and warm IV fluids and irrigation solutions were used. Optimal depth of anesthesia was maintained to avoid the coughing or straining by the patient, and intermittent positive pressure ventilation airway pressures were kept to minimum. Post completion of the surgery, residual neuromuscular block was reversed with the injection neostigmine. Throat path was removed and patient was extubated fully awake. Patient was instructed to breathe through mouth as the nose was packed. What were our post-operative concern? Risk of aspiration, bleeding from the surgical site, adequate urine output, hypothermia and shivering, and post-operative nausea and vomiting. Now I would like to invite Dr. Priyanshi for further management.
Thank you, Dr. Disha. So moving on to the surgical management of this patient, endoscopic sinus surgery can have a very wonderful support of microdebrider which reduces the sinus mucosal damage and bleeding along with a coablator which provides an excellent hemostasis. So this is a surgical video of the surgery that was performed. The total duration of the surgery was 4.5 to 5 hours. The first step on our right side nasal cavity is uncinectomy, which is a single bone. Here we can see the allergic mucin, which is very thick, tenacious with extremely dense elasticity. The challenges we face while removing this mucin is because it is so thick, it is difficult to suction out. We need a close to 3 to 4 suctions to pull out these mucuses from deep crevices of the sinus cavity, because leaving this allergen load will lead to recurrence. So this is the maxillary sinus that we can see which is being cleared off. We do a medial maxillectomy, which is we widen the ostia of the maxillary sinus. While doing this, we need to be careful of the nasolacrimal duct, which can be traumatized and can lead to epiphora. This that we are clearing right now is the frontal recess to approach the frontal sinus. Frontal sinus is a very hidden sinus, and accessing the sinus is a difficulty, especially in these patients who have an excessively hyperreactive mucosa, which is continuously bleeding like we can see. So while accessing the frontal sinus, there is an anterior ethmoidal artery which is very low lying and can be damaged. Damage to that artery per se is not a problem, but retraction of that artery into the orbit leads to intraorbital hematoma, which can lead to progressive vision loss within 2 hours if not treated. So extreme care is taken in order to not damage the anterior ethmoidal artery. This is the posterior ethmoid sinuses which are being cleared. By clearing these sinuses, extreme care is taken to not pull inadvertently on the sinus mucosa, as that would lead to damage of the cribriform plate and CSF rhinorrhea. So the last sinus that we are clearing is the sphenoid sinus. Sphenoid sinus is in close proximity to our optic nerve and internal carotid artery. Therefore, no sharp instrumentation is used. This that we are seeing is the classic completely opacified sphenoid sinus filled with the allergic mucin. This is an empty and a clear sphenoid sinus that now we can see. The similar procedure was repeated on the left side, where the first step was again uncinectomy, followed by middle meatal antrostomy, clearing of a frontal sinus, moving on to clearing anterior ethmoids, posterior ethmoids, and sphenoid. The challenge was to minimize the blood loss and use very sharp instruments in the nasal cavity and preventing its use in the sphenoid sinus. This we can see is the complete clearance of the maxillary sinus with completely lowered down in medial wall of the sinus. In the post-op treatment, we started the patient on injection methylprednisolone again with an antibiotic cover, a decongestant and other supportive treatment. The patient had nasal packing for 2 days, after which it was removed with no bleeding, and then was started with nasal douching to prevent crusting formation over the sinus mucosa. Was discharged on post-op day 3.
Thank you. Thank you, ma'am. Good morning, everyone. So I am going to discuss about the pathological aspects and show how this disease looks in our blue and pink world. So we received the specimen from paranasal sinuses, which was measuring 4 cm in its greatest dimension. So this is a picture showing multiple polypoidal soft tissue beds, which is greyish brown in color, mucoid, tenacious to soft in consistency. So after taking multiple sections and examining them under microscope, this is a picture showing allergic mucin, showing laminations which are composed of predominantly degranulated eosinophils, necrotic epithelium, and cellular debris. In figure 2, we can appreciate degranulated eosinophils which are smudged. So considering H&E stain, we suspected that there could be any infective pathology. So for that,
we applied a special stain, that is gomorimethanamine silver stain. So on that stain, we appreciated a fungal hyphae which is slender, septate and show acute angle branching. So to sum up, after all the workups, these are the characteristic features. Eosinophilic allergic mucin with red and blue ripples showing laminations. This allergic fungal mucin composed of cellular debris, epithelium, degranulated eosinophils and necrotic epithelium. Eosinophil granules are predominantly smudged and show degranulated changes, which led to our final pathological diagnosis as allergic fungal rhinosinusitis.
Good morning, respected teachers. I'm Dr. Rachana, going to cover the microbiological investigation to the sample which we get in our department, that was post-operative sinus surgery. Post-operative sinus surgery, tissue and debris. Our lab investigation was covered under two headings. First was direct examination and second one was fungal culture. Under direct examination, first of all, we performed the KOH wet mount of the specimen. In KOH wet mount preparation, first we put the tissue in, dissolved it into the KOH solution and kept it in the incubator at 37 degrees centigrade for 2 hours. It was mainly done to soften the protein debris so that fungal structure can come up very beautifully and clearly. And our microscope, and then we saw it, then we made a slide and saw it under low power 10x and 40x. And our microbiological finding shows thin hyaline septate hyphae with acute angle branching. Then we performed fungal culture from the rest of the sample. The sample was minced, which means it was cut into small pieces and then cultured in Severod dextrose agar bottle. There was total 2 set of 2 bottles. That means total 4 bottles were inoculated. 2 bottles were inoculated at 25 degrees centigrade and 37 degrees centigrade. The purpose of 2 different temperature is 25 shows the room temperature and it is more favorable for the mold short of fungus growth, and 37 degrees centigrade it shows the body temperature and the yeast grow more favorably into this. Then we, according to our protocol, we examine our fungal culture daily for the first week. Then for the second, third and fourth week, we examine the culture bottle at gap of 53 days. In 4 days, in our 25 degrees centigrade, we have kept 2 bottles. They shows velvety greenish brown colonies. At the reverse, it was brownish appearance. Then we made LPCB, that is lactophenol cotton blue teas mount. We prepared it from the growth which we obtained on the SGA agar, and this is our finding. So we found thin hyaline septate. Here is the septation, septate hyphae. There is a long conidiophore. Then there is a this is the vesicle. This dark purple color is the vesicle, and there is the filate which surrounds the vesicle, and from there conidiospores arises. As the conidiophore, as the filate don't cover the whole vesicles, then it is suggestive of Aspergillus species, and mostly it suggests towards the Aspergillus flavus species. Definitely to talk about. That's all. That's all from our side. I will call ma'am.
You said that you were not planning and you did not give any antifungal treatment. So why did you go to the extent of identifying the species?
That is the protocol. We identify the species.
Otherwise also.
But otherwise also it had been mucored. It had been mucored, then you would have needed to give in the antifungal. If it is Aspergillus, you will not need to give the antifungal, but with mucor maybe you will have to. And it could also have been a rhinosporosis, Sporidium seaberry. That would change the. So it is muted.
Thank you, ma'am.
moving on very quickly, the 1 month follow-up, like we can see, is a brilliantly clear, very nicely mucosalized nasal cavity on the right side, which is showing some amount of crusting. The crusting essentially is a positive feature. That means it's showing that the mucosa is being functional and the mucosal clearance has been re-established. The same kind of nasal cavity we can see on the left side with very nice mucosalized all the sinuses, and at the back we can very nicely see the grade 2 adenoids, which are very synchronous with the age of the child. So the boy was had completely resolved eye symptoms with no proptosis, normal vision on day 10 itself, no nasal obstruction and discharge, improved sense of smell, and stopped mouth breathing and snoring. So the ongoing treatment was steroids orally for 3 weeks. As this is 1 month, we had stopped by then. Then we put the patient on topical steroid in the form of mometasone spray for 3 weeks, and then with nasal steroid irrigation. So we take a budesonide Respil of 0.5 mg per 2 ml, diluted in a 200 ml saline, and ask the patient to do douching with that particular saline. Counsel the child and the parents for atopy and allergy testing, which is done after 8 weeks of surgery. There was no symptomatic treatment requirement at present at 1 month. So briefly about the literature review, we need to understand what is FRS, which is fungal sinusitis. It is divided into non-invasive and invasive variety. In the non-invasive, we have fungal colonization. So to elaborate, it is an immunocompetent patient with impaired mucociliary function. Any fungus, any species can give this. Fungal ball, immunocompetent, impaired mucociliary function but non-atopic. AFRS, immunocompetent, impaired mucociliary function but atopic. So invasive fungus, we have acute invasive, which was muca, we all know, in which the critically ill patient will give rise to this. 96% of this mucormycosis cases are from mucus species, which is mucor rhizopus and Ipshita, but in neutropenic patients we see a more prevalence of aspergillus. Chronic invasive are those patients who are not critically ill but mildly immunosuppressed. For example, the patient is on long-term steroid or who has an uncontrolled diabetes. In these cases, we see chronic invasive variety where the invasion is taking place but longer, so more than 12 weeks. Then the granulomatous invasive is a very distinct variety we see in India and some parts of southern US, where we find a non-caseating granuloma, again in response to aspergillus allergy. The Th2 starts producing IgE antibody. That is the signature immune response that our body gives in response to a particular allergen. It can be a fungus, it can be a pollen, it can be dust mite. So I just want to briefly explain the pathobiological mechanism. What happened? What happened was the aspergillus fungus came in contact with our mucosa. The mucosa had innate lymphoid cells which are deranged, which led to activation of beta cells, which led to activation of Th2 immune response, which led to the activation of B cells secreting IgE antibodies. These antibodies then went and bound to the mast cells, which then released granulation. An interesting thing to note here is the Staphylococcus aureus. Now, if it is a fungal pathogen, what is staph doing here? We all know staph is a bacteria. So staph in repeated studies have been found to be acting as a super antigen. Now, super antigen is nothing but an antigen who's actually instigating the main antigen to give a very hyperactive immune response of Th2 cells. So what is our understanding till date? Like sir mentioned, in 1976 we knew clearly about what is ABPA, which is allergic bronchopulmonary aspergillosis. So when we found AFRS, we thought it is a sinus variant. Then we realized that only 3% of the cases have concomitant to problem. That means it's clearly obvious that the biopathological mechanism is different. So then we evolved and we understood that maybe it is a fungal sinusitis. Then we realized no, it's not responding to antifungals. Then we realized maybe it's a phenotype of CRS itself. But then no, because in spite of giving only steroids, there was no improvement. It is now that we understand that it is a type 1 IgE-mediated hypersensitivity reaction to a fungal antigen in an atopic individual, which is AFRS. So we had to break certain concepts which were very well established. That is, it is not the species of the fungus which is the problem. It is any species of the fungus and its response with our immunological system that gives the particular problem that we face. The second is a geographical fungus. That same fungus has been found to be indolent in US but invasive in India. So in India we see that when we encounter AFRS, 96% of them are aspergillus. So we've reached the halfway mark by reducing the allergen load by doing the surgery. What is the remaining half? We have to prevent the recurrence. Since we know it is an allergy, it will come back. We have to manage the atopy, and we have to halt the atopic march. Atopic march is a child born as atopic, having atopic dermatitis in his infancy, moving to food allergies in early childhood, moving to AR in her teenage or his teenage, and then progressing to asthma. So ideal stage to stop atopic marches in early infancy, but usually it is diagnosed at later stages. So the ideal thing is to stop the presence of asthma. Now the steroid rationale. How much is steroid, what steroid, and why? So oral steroid ideally for 3 weeks, followed by topical steroids, followed by steroid irrigation like we did for this patient. Then what is the role of giving an antifungal? There is no role. We have had repeated RCTs proving that there is no role of an antifungal in a patient of AFRS, which is unlike the case like sir said with ABPA. In recalcitrant cases of ABPA, since you cannot go to the bronchus and keep on debriding the fungus, you have to have an antifungal as a backup. But in sinuses, that is not the problem. With good nasal douching, with clearing of the sinuses, the allergen load is anyway reduced. It was only in 2019 that the FDA approved AT. AT is allergen immunotherapy. Immunotherapy is you give that particular allergen in very small doses such that your immune system becomes immune to it. So how do you do it? And why do we do it? We do this because we have seen that 2/3 of these patients are atopic and 50% of them will progress to becoming asthmatic. Then when do we do it? Ideally we do it after 8 weeks of surgical treatment. And how do we do it? We have 2 methods of doing it. One is skit and the other is slit. Skit is subcutaneous that we inject and one is slit that is sublingual. In India we give skit which is more prevalent than slit. But what was our concern? Why did it take until 2019, 50 years after diagnosing AFRS to actually approve this AT? It was because the concern was since immunotherapy will start giving IgG4 antibodies. And these IgG4 antibodies will go and bind with an antigen. And then they will form an immune complex. So this immune complex will give a serum sickness-like reaction. So we were concerned that immune complex reaction should not take place. Then we started doing studies and found that this was not the concern. Immunotherapy is very well validated and now approved. The last is biologicals. We know anti-IgE antibody like omalizumab, interleukin-5 like mepoli, and 4 and 13 like dupilumab have been approved for CRS with polyposis. However, they are in phase 3 trial for AFRS. So what is our take-home message now? Fungal rhinosinusitis, we've seen they have had a changing trend since past 50 years. We first thought it was ABPA, then we thought it is fungal. Now we know it is allergy. So it has had an evolving management as well. Endoscopic sinus surgery is multidimensional. We have seen the same surgery had a very different rationale for mucor and has a very different rationale when we do it for AFRS. Then there's hypertensive anesthesia, which is a must essential requisite because this child was 9 years. A 400 ml blood loss was enough to put that patient into hypertensive shock. So hypertensive anesthesia is a requisite. So patho, micro and radiological investigations are fundamental in diagnosing and holistic management of CRS cases. And atopy is a phenomenon of concern which we should all see, which necessitates workup, counseling and treatment for a lifelong good quality of life. Thank you.
When you said allergic march, my question is, would all children with atopic develop asthma?
No.
No. So, one. Number 2, most children who have food allergy, they develop immune tolerance. For example, if you have milk allergy, egg allergy, or crustacean allergy, or nut allergy, most of these children are going to grow out of the allergy by the age of 2 to 3 years.
Absolutely.
So, when you said you are trying to prevent a child to get into asthma by doing immunotherapy, I think that I have quite
So the child was already on the stage of allergic rhinitis. So we have seen the progress. However, there was no food intolerance or food allergy. Intolerance and allergy are different things. I can be intolerant to something but not allergic. So this child had no food allergy, had eczema, and now has AR symptoms on and off like we saw in the history. So we have seen that the atopic march is progressing. Hence we counsel for AT. Had we stopped after food intolerance or food allergy, not progressing to AR at the age of 9, we would have probably waited. And also, sir, allergy testing is essential. Once we have done an allergy testing and responding and we found a particular allergen, we will counsel for immunotherapy.
There's another question. When you said allergy testing, what do you mean by allergy testing? For me, IgE does not mean anything.
Absolutely, sir.
It has to be a skin prick test.
Or a RAS. So skin prick testing we do, we take a very detailed history of the allergen that is
skin prick test in this case?
No, not yet sir. अभी तो बच्चा 1 महीने follow up में है. We ideally counsel for any allergy testing after 8 weeks of surgery since the child is on steroids. So when somebody is on steroid, we can't do testing anyways. So we will stop steroids and then we'll counsel for allergy testing. So sir, we do allergy testing if required after 8 weeks of surgery, stop the steroids for 3 weeks and then counsel for
One more question.
Yes.
One more question. Is kit available in the country?
Kit?
Yeah.
Yes.
Is it routinely available?
Very, no sir, it's not very routinely available, but kit is available, very much.
Is it marketed in India?
Sir, subcutaneous हो रहा है, जयपुर में हो रहा है.